afternoon. Welcome to our, what we think is the 4th annual focused updates in pulmonary critical care and sleep medicine. Debbie and I were just confirming it's either 3 or 4. Anyway, we like this format. There are a lot of things that don't maybe need to spend an hour on, but a lot of us have a lot of expertise in different areas, and the idea is to share some of the things that might not rise to a full hour, but are of great interest and good educational value for everyone. We always try and mix some inpatient and ambulatory as well. So looking forward to it. I will just list the 3 speakers. I'm not going to go through their full CV for the sake of time. So first we have Dr. Elaine Fajardo, who's the Medical Director of Respiratory Care and one of the core critical care faculty, has spearheaded a lot of our respiratory care initiatives, including during the pandemic and more recently, a rather last minute but needed upgrade in the ventilator fleet. So she's going to give an update on that. Then we have Dr. Sebastian Kurz, who actually was here 3 or 4 weeks ago, talking. He's the director of the COPD clinic, and he has special expertise in COPD as well as bronchiectasis, and recently arrived here from Germany. And he'll be talking about some of the new medications and biologics for COPD, which is very exciting. Last but not least, Dr. Finbar Foley, who has developed an interest in neuromuscular disease and as well as non-invasive ventilation. And just saying that's been like a group of patients that has migrated from practitioner to practitioner over the years. And I think now there's finally a home rather than being passed off. But Dr. Siegel did it. I did it for a while, several other people. And now I think you've wrapped your arms around a bunch of it. So that's exciting, and we will hear about what you have to say. So with that, Elaine.
Everybody, hello. I'm so excited to be invited here to talk to you about something near and dear to my heart, which is the mechanical ventilators here at Yale New Haven Hospital. And so I wanted to give you a quick update. As Jonathan said, there was a long, protracted advocacy for new ventilators that suddenly became an urgent need. Thankfully, some companies went out of business and got bought out and whatever. But we have new mechanical ventilators, so I want to tell you all about it. I realized last night and this morning that references to space might be a little triggering, but I hope you excuse all of that. As a Star Trek fan, this is the next generation. So exciting. Okay. All right. Okay. So first thing, this is what the ventilator looks like. It's a Hamilton C6, the most recent version of Hamilton's. What's new about it? Well, first and foremost, when you look at it, it provides clinical information with really enhanced graphic user interface. And this interface can be adjusted and personalized to each individual provider, patient, what have you. I'm going to show you how to do that a little bit. So I like to say it's as if Apple married Android, and being an Android person amongst Apple people, I feel that this is like a very good thing. And I can show you what exactly I mean by that, but it's very adjustable in how it presents its information. There are set formats for waveform and graphics. However, the user can easily toggle among them, and the vent interface can look different on each patient. Now, being a big institution, we'd like to standardize how it initially appears. And so when patients are placed on a ventilator, we do have a general look to it, which I'll show you, but certainly that's adjustable. These new ventilators offer invasive ventilation, obviously, but also NIV and high flow nasal cannula. And thankfully, it's on the same circuit, which means that for people who are really interested in practicing hot new evidence-based medicine, like the pre-oxy trial, where we pre-oxygenate patients on NIV prior to intubation, This machine can do it. And prior to having this machine, because there were so many, we needed the respiratory therapist to get the NIV machine into the room and then get the ventilator into the room, and the patient might be crashing, kind of a thing. We were not able to do that efficiently for everybody. In addition, for post-extubation patients who are high risk for reintubation, we can now offer NIV and high flow really readily and available. There are also additional tools and modes that are offered on this ventilator, which I will talk about as well. Okay, so first, I just wanted to introduce you to a change in the nomenclature, so you've at least seen it. For the Hamiltons, each company itself has like proprietary nameage for their modes. So the volume control, which Avia called VAC or AC, is now called SCMV. And the pressure control is called PCV plus, and pressure support or PSV is called CPAP SPONT. And that will be what you see on the ventilator. It's also what Epic will prompt you for when you're ordering it. So the SCMV is probably the one we use the most here. So at least you're familiar. The other modes are available, and that would be the SIMV, PRVC, which is APV, PRVC, SIMV, which is APV, SIMV, and then pressure control SIMV, which is PCV, SIMV. Got it? For those of you that are like, what? We did place a card on the ventilator that is laminated so that you will not have a problem with this, I hope, until we get used to it. And then obviously NIV and high flow are available now. Okay. All right. So what does it look like on the home screen? Well, this is an example, and I said this is very this is able to be modulated, and so this is the first version that you should see that the RT does put up. And what I will point to is this side here, which is the monitoring side. This gives the parameters and the measurements that come off the ventilator that tell you about the patient. The top number is the peak pressure. Then you have the expiratory tidal volume, the frequency, so the respiratory rate, the minute ventilation, and then the FiO2 that is being administered to the patient as the sensor reads. The middle portion is where the graphics are. And traditionally on the Avia, we've seen graphics where you have 3 sets of waveforms. This has actually been modified so that we show the pressure and the flow waveforms. And then we have 2 boxes for graphics here. This one is called the dynamic lung, and I'll explain what that is. And then the one over here shows parameters for spontaneous breathing trial, which usually is only useful if your patient's receiving trials. The next thing I want to draw your attention to is this on the right side, right under the label modes. And this is the settings of the ventilator. What you'll see here that's missing is is the setting for flow. On the Avias, that's readily available on the first interface, and we didn't have to necessarily toggle looking for it. But the flow is not available here from first blush. You do have to click in to get more information about that. And it's correlate, so like on a pressure mode, the inspiratory time, also you kind of have to click on it to get it. But that is that information. And then over here, these are tabs that allow you to toggle through different things and get access into the ventilator. And I'll go through that in a second. So on the left side of the screen, again, this is the monitoring side of the screen. Here is, if you remember what the Avia looks like, this is what it looked like. The order of the numbers of what is appearing there is different. So I found when I first went to the MICU, instinctively, I looked at the left upper corner and thought that was the respiratory rate, and I was wrong. So you do have to sort of readjust. The respiratory rate is the 3rd number. Okay, down here. Here, the graphics have been adjusted so that you do see the 3 waveforms that is something that is easily available. If that's how you like it, you can certainly change all of your vents to look like this. Okay. If this monitoring information on the left-hand side is not enough and you are looking for more information, then you can click on this bottom tab here called monitoring, and much more information will pop up. Okay. The things I wanted to highlight as information available to you here, for one, the delta P is available in case you didn't feel like calculating it. And that's right over here. The flow is right over here. So your inspiratory flow rate. And then tau, so the amount of time it takes to exhale, the 3 tau is calculated. The one caveat from that, and I will point to 3 other numbers that are available here, the static compliance, the resistance, the respiratory system resistance, and the plateau pressure are all listed here. I will say that in the ventilator, these numbers, particularly the plateau pressure, are derived from micro-occlusions that occur during the breath that the machine is making. It is not from a measured plateau pressure that the respiratory therapist is making. And so, therefore, the calculations made from that plateau pressure, including the resistance, the compliance, and tau, are also approximations of a number. What does that mean? I sort of feel like that means that we should use those numbers as approximations, sort of like how we use the end-tidal CO2 monitor. We don't necessarily take the absolute number, but we say, oh, if it's trending up, then that's something. So if the compliance is trending up, then maybe that's a good thing. And if it's trending down, maybe that's a bad thing. And that we should actually check a plateau pressure and calculate the real number, which the RT will do. And that is the number that's recorded in Epic. So when you're looking at Epic, you have actual respiratory therapists validating a number which they've measured. Whereas if you're just looking at the ventilator, these numbers are approximations from this microocclusion during the breath. Okay. All right. So I would take this opportunity to highlight a feature of this ventilator, which is the flow sensor. The flow sensor on this ventilator, unlike the Avia, is external. And it's not inside the vent, so it's closer to the patient. And it's thought to therefore have more accurate breath-to-breath measurements of volume, flow, et cetera, and pressure. The downside to this, so here you see the sensor, and it's blue, and it's next to where the patient is. The downside to this, say this is the patient, is that this ventilator, I had a hard time drawing. No, it's a little ghastly. This flow sensor has to be kind of vertical. It has to be at least upright and vertical. It is sensitive to condensation, so it tends to build condensation. Certainly secretions can still reflux into the sensor and clog it if it's hanging down. And so we've been talking to nursing staff, but your residents, your whole team, if they were just a little more aware that the circuit should be on the arm of the ventilator, so this arm is holding this nicely up, it'll work better. And I did notice from a clinical perspective, there's a little more artifact in the waveforms because of this situation. Thankfully, these sensors, they are changeable, disposable, but they're also pretty durable. So you can just pop them off, shake them out, try not to get anyone wet, and then, pop them back in, and it's good to go. It improves the situation. So I wouldn't blow dry it though. That was kidding. All right. So what does the flow sensor location mean for us? Well, like I was saying, the ventilator can now do these microocclusions, can take more accurate pressure readings. It can attempt a microocclusion with the plateau pressure. And therefore, it gives us additional information that we can use. Again, I would, when I've been paying attention to this since the event came out, these estimations are actually pretty close. But that's probably all I'll say about that. But you can find that information there. Okay. And so just to reiterate, we use these numbers, we can trend them. I would really use the actually measured plateau pressure and therefore the calculated resistance compliance from that numbers. The advantage of this is that prior to the Hamiltons, when we had the Avias, you used to see plateau pressures being measured, and due to the workflow of the respiratory therapist, sometimes that plateau pressure didn't make sense. Sometimes the patient was inspiring during the plateau hold, and you just knew intuitively that it was not valid. Well, here, every plateau pressure that's measured, the RT is made to look at the waveform, made to assure that there's zero flow occurring when they're measuring the plateau pressure. So I'm really happy about that. I think it's good. The external flow sensor, if anyone's paying attention, will trigger more sensitively. And so the company has recommended to us that the flow trigger, really the starting setting should be 5 liters per minute. For those of you that have been paying attention to this on the Avias, we usually start around 2 or 3. Don't go down on it. Like this is this is due to the location of the sensor. Okay. All right. So now to the right side of the screen, this is where our settings are. As you remember on the Avia, that was at the bottom. And you'll notice what's missing from here is the flow setting. So if you want to see the settings on the ventilator and you want to know what the settings are, you would press on this control button here on this side of the screen, and this screen will pop up. You will notice this is where the flow is recorded, but also a flow pattern. And we actually have 3 flow patterns available. So previously we had the square waveform, we have a decelerating waveform, and then on the Avias, which was not really maybe talked about too much, we had a decelerating waveform that when it hit 25 or 30% of flow would drop down to 0. So it was a drop-off ledge. That was the default mode of the Avia. It was not changeable. But on this ventilator, we can have all 3 options. We can have that deceleration to the 25, 30%. We can have a pure deceleration down to 0, or we can have this square waveform. I would say that if you could tell your residents that if they want to take a picture of the ventilator so they could put the order in the chart, this is the picture to get because this has all the information. Whereas on the Avia, you used to take a picture of the home screen. Not so much anymore. So, all right. If you want to change the home screen layouts, I've been talking about how you can, this is very interactive ventilator. You can change things around. You would go to the graphics tab here at the bottom, and you would change the layout form. The traditional Avia with all the waveforms on the front page is layout number 1. The RTs, and as an institution, we have chosen to pick layout number 2, which I'll show you as a basic form, but certainly you have other options. So this is the Avia layout where you have the 3 waveforms, pressure, flow, and volume time curves. This is the presentation that we will default to here, where we have the pressure time curve, the flow time curve. And we switched out the volume time curve because I think we don't use that so much in our decision making. And I have put here the pressure volume loop, which I think is very useful. And then over here is for the spontaneous breathing trial. This is a graphic which reports out 3 different categories of patient parameters: oxygenation, CO2 elimination, and spontaneous activity. And this white area is the parameters that we find acceptable. And so if the patient meets the criteria, this silver bar will drop down into the white area. When all the bars drop down into the white area, the whole thing turns green, and then it starts counting the minutes. So you know how many minutes the patient was in where all the parameters were green. So an example of your patient's doing 30 minutes and they immediately fall into passing parameters, this would say, 30 minutes on and be very green. Okay. I think this is only really useful if your patient's on minimal vent settings and you're doing SVTs. So I change this on my ventilators, and that's something you can do. So if you want to change your graphic, you go to, you click on the graphic that you want to change. So say this left-hand corner graphic that has the pressure volume loop, say I want to put it on. So I'll click the bottom on the other screen. This will pop up, and then I can pick which loop I want to put in here. And when I click on it, it'll show up. So there it is, and there's the pressure volume loop. If I wanted to change the side that had that SBT trial graphic, I would click on this box. I would just touch it, my finger, and I would go, this page would pop up again. And then I might go to graphics and pick a different picture or something like that. So this is, I'll call this the Fajardo favorite. If you see this on a ventilator, it's because I was there. But it's the 2 waveforms, the pressure volume loop, and then monitoring. So this shows you what the tau is, the delta P, which I think is probably the more useful number, just having it readily available. And then you can, if you're interested, look at, eyeball the compliance and the resistance. Again, these are trend numbers, not actual numbers. Okay, so another difference between the AVIA is which is a patient-triggered breath versus a machine breath. And this is denoted by this pink dot, which appears underneath the breath. Okay. Checking a plateau pressure. So this is something that a lot of us like to do in the moment. In order to do it, you click on the tools button down here, and then you press inspiratory hold. On the very next breath, the hold will start to occur. The hold can occur for up to 10 seconds before it times out. But I encourage you, especially on a sick patient, to time it out before then. So you just click the inspiratory button again, and it'll, after 2 or 3 seconds, should be good enough. Okay, so again, that's the tools tab that you would be looking at, and the inspiratory hold button. Once you do that, this screen will appear. It will be a frozen waveform. And what you see here is on the pressure time curve, you'll see a flat plateau. And you will use the knob on the ventilator to scroll the cursor to a 0 flow setting. So where flow is 0. And flow is being reported over here. It's very small numbers. I think I have an example that'll show you it close up on the next slide. And when flow is 0, then you would read the airway pressure, and that'll be your plateau pressure. Oh, yes. So here is the example. You can see the airway pressure is 21 when flow is 0, and that's the hold. Okay. If you want to do an end expiratory hold, so you're curious about auto PEEP, this patient has a little. So here, again, you go to the tools button, you click end expiratory hold. This screen should pop up. It is frozen. And then you use the cursor to toggle to a 0 flow. And you can see here the airway pressure is 12. I cut it off, but the PEEP is 10. And so there is some auto PEEP too that is there. When you're done, you unfreeze the screen. And this is the button you have to press to unfreeze the screen. I always forget that and it takes me forever to find it, but that's it. I'm getting better at it. Okay, now your patient's desatting. The other clinical thing I wanted to tell you was about suction or 100% FiO2. How do I quickly do that? The 100% FiO2 button is this arrow with the O2. So it's pointing up, like your O2 is going up. I think it looks like a house. So I'm a little challenged with this, but that's it. And it will put you on 100% oxygen for 2 minutes. And then this is the alarm button. Obviously, if you're going to suction, you'll want to silence the alarms. So that's what that's for. And then finally, I wanted to mention this graphic. This is sort of a new thing that's available on the ventilators. And it will be on the ventilator, I think, while we're getting used to using them. So what's available on this? Well, first, you have some information about the patient. All of the patients, their height will be plugged into the ventilator at the time that they are intubated or that the vent is initiated. And so automatically the default volume will be 6 ml per kilo, which can be adjusted, but at least you'll know kind of where you're starting on the patient. So some of the patient information about ideal body weight and height is available on the left-hand side. And then just a graphic representation of the lungs. So here we have like normal shaped blue lungs and then the airways. And the idea behind this picture is to kind of visually represent whether there's a compliance issue or a resistance issue going on with the patient. Again, the resistance and compliance are taken from these micro occlusions that are not actual plateau pressure based measurements. Okay. So what does it look like? So when your patient has a resistance issue, then the graphic will show, will go from this beige color to a more red color. And actually this is it's not really truly representing how red it is. It just turns red, the whole thing. And then if you have a compliance change, so normal compliance is this representation in the middle. And as the patient's compliance drops, the baby lung inside becomes more trapezoidal in appearance. That's a trapezoid maybe. And if your compliance is actually high, then it becomes more balloon shaped, but it no longer matches the shadow of the normal lung. So you can see that there's a darker outline and that the shape is generally changed. Those are the things you want to know. And that's it. So in conclusion of this, those are the basic kind of features of the ventilator to get you going in the unit. I will say that coming March, April, we will be launching the use of some other cool tools. As I said, this is the next generation, the vent of the future. Pretty much everything I talked about is like the vent of the past. So what will we have available? So this ventilator has a PV tool, which they call the protective ventilation tool or pressure volume tool. And this records pressure volume relationship of the lungs at low flow states. When used in conjunction with esophageal pressure probes, it will help us maybe target ideally the PEEP that we would want to use on the patient and have a better understanding of transpulmonary pressure. Particularly for very sick patients. So the esophageal pressure probe is still something that's extra that needs to be inserted to a patient. So probably not something that we would have on every patient, but at least for our very sick patients or patients who have like abdominal or other complicating other issues that may be impacting their transpulmonary pressure, we have an option, a readily available option. And so that feature and the training for that is probably going to launch in a couple months, and I'm very excited about that. And then there's something called adaptive support ventilation, which is a closed loop ventilation, wherein you set the respiratory rate, the minute ventilation, and a peak pressure limit, and the ventilator pretty much has at it in managing your patient's vent settings. We will talk about this mode It will be available. It's not currently available now just because it requires some training. I think that I imagine that it'll be something that's very useful, perhaps in patients who have pretty stable respiratory failure or minimal pathology respiratory failure that's uncomplicated. So maybe on the surgical side or post-op side or something like that. Certainly open to exploring it more in the MICU. We'll see how that goes. And then finally, the other exciting thing is the high flow nasal cannula and the NIV that will be available. The number of ventilators that we have in the ICU, particularly during flu season, is limited. And so we ask that you don't immediately put all patients on ventilators if all they need is high flow and NIV. But certainly if you're thinking about intubating them, if they're really in that peri-intubation, pre or post intubation phase, this is something that we can use, and it's also very exciting. One last thing I wanted to talk about. I know all of you have been, collaborators in the ICU in terms of the care team. I just wanted to highlight, because these ventilators are interactive, people will be touching them. And very much so, while I encourage people to touch the ventilator, we do have a policy here at Yale New Haven where adjustments made on the ventilator are really left to the respiratory therapist. This is to ensure patient safety. This is to meet regulatory guidelines. And it's something that we really have to adhere to. I would ask all of you to be representatives and leaders in sort of the team and using the respiratory therapist as a collaborator, particularly because these ventilators are new, that everybody's eager to learn what you have to teach about them. And so calling them into the room before you make changes and using a respiratory therapist is just really encouraged. You can, according to the policy, make changes when there is an emergency. Hopefully that's not a common event. And then finally, I'm Elaine Fajardo. This is my contact. Nicole Gizzi is our educator, and happy to hear any feedback and any suggestions you have. Thank you.
You have any questions before we move on?
Yes, get signed off.
Thanks. Just really quick, Elaine, that was great. And I think you didn't mention, I think they're quieter than the other ventilators. At least that was my experience this weekend. Just to be clear, because I don't want to make a mistake, it's okay for us to change the graphics, but not the settings. Is that right?
Order and documentation in Epic, which is perfect. Oh, sorry. Yeah. The setting changes need an order and need documentation in Epic in order to meet regulatory guidelines and patient safety. And so that needs to be done in conjunction with the respiratory therapist. So just encourage you to reach out. Yeah, yeah.
Thank you. Hey, Elaine, that was great. I think the house button means the oxygen's from the house. I think it means the oxygen's from the house. No, but it's just a quick question about the flow sensor. So we have these patients with massive pulmonary edema or alveolar hemorrhage. Is that going to get in the way? So is that an instance where we shouldn't really look at those numbers on the more descriptive screen at all?
Only if you see that the sensor's been gunked up, and usually you can tell because the waveforms themselves have a lot of artifact on them. Similar to how it would look if on occasion some of that stuff has gone back all the way in the AVIA down to the sensor through the circuit. But most of the time, I think you can see it on the sensor that there's condensation there. And you can also remove it pretty easily. If your patient's not too unstable, you can clean it out and put it back.
Foley?
Quick question. I saw in your slides what I was seeing at the bedside for most of the patients on 10-7, which was there was nothing being reported in the plateau pressure. That was always a blank. is there something going on with the microocclusions and the reporting of that? Or when I put in a delayed inspiratory time and gave a little bit of inspiratory holds, like then it started reporting it sometimes, which I noted on the Avia. When we used to give inspiratory holds, then it would report plateaus. But in all of your pictures up there, it just had like the 2 dashed lines there.
Yeah.
What's going on?
Yeah, I asked the rep about that. It sounded like the machine had high scrutiny for the plateau pressure that it would report. But it does occasionally meet the criteria and then pop up. And I've seen it, but you're right. It doesn't always pop up. And the number when it does pop up is what they use to calculate. So that numbers, the calculated numbers seem to be much more frequently present.
Dr. Singh?
Do you know when the esophageal balloon and pressure setup will be starting? Because we're placing more bedside swans. It's a lot easier to place an esophageal probe when the patient's intubated than when they're not. And knowing what the esophageal pressure is, you can mitigate the effects of respiratory swings and positive pressure. You know, it's already a less an ideal scenario when you swan them at the bedside, and I want to, sort of minimize anything that can affect the hemodynamics, and positive pressure being one of them.
I'll email you. Our first workshop is March 24th in terms of educating providers. So by the end of March, beginning of April.
Next. All right, Dr. Foley.
I promised Sebastian to make him look good, so I'm going next. So, wrong pointer. So, thanks for being here today. As some of you may be aware, I've been developing a niche interest in the outpatient clinic in the care of patients with neuromuscular disease and respiratory complications thereof. And so the point of this talk is a little bit of a primer for the difficulties sometimes in getting non-invasive ventilation for patients, which we encounter on the inpatient side, but also outpatient. So a little bit of a background on why those difficulties exist and maybe how to circumvent or at least navigate those issues. And then a little bit about kind of the initial empiric or titrated settings for patients and how we kind of come up with our initial starting settings. We won't get into kind of subsequent titrations since that's a little bit more complicated moving forward. The talk will have hopefully some high yield images. I'll point them out if and when you would like to take a photo or take a QR code for the relevant thing. I'll let you know, hey, this is one of those slides you might want to keep for records. So we'll start off with talking about the new ACCP guidelines, just mainly just to let you know that they exist, how to get NIV approved, the initial settings, and then tips for ResMed devices. Since Philips is less available now, we're seeing, of course, much more in the way of the ResMed devices, specifically the Astral. And it does have some different settings that we need to be aware of as opposed to the trilogy with which we were all familiar. So this is one of the useful slides for those of you interested in optimizing your care of patients with neuromuscular weakness. This QR code will send you to the 2023 CHEST ACCP guidelines. And the list over here on the left is the various headings for the PICO statements relevant to the guidelines, namely how we approach PFT use and timing, when to use NIV, what the respiratory parameters for NIV are, using invasive mechanical ventilation, management of sialorrhea, and then airway clearance in this population. And so if you happen to have patients on the inpatient side or ones that you're following in clinic that I'm not taking care of, and you want to make sure that you're adhering to, kind of the best possible expert guidance, this document will get you in that direction. I was granted a little bit of extra time by Jonathan, and so I had some slides at the end that I'll actually now just skip to. regarding one particular talking point from that position statement from those guidelines. So they drew their recommendations on the initiation of non-invasive ventilation from the ONMAP Technical Expert Panel in 2021. And so there were technical expert panels for NIV and COPD, hypoventilatory disorders like OHS, neuromuscular disease, and restrictive thoracic disorders. And as we all know, we have a great deal of difficulty in navigating those CMS guidelines for, okay, you know, I have to get the overnight oximetry less than 5 or greater than 5 minutes desaturation, and I have to have ruled out COPD by spirometry, It can be very difficult to get our patients qualified, particularly in the inpatient setting. So the ONMAP technical expert panel was put together in order to come up with recommendations for CMS to try to update the qualification guidelines and providing evidence-based rationale why the old guidelines just don't make sense. So in the neuromuscular population, we highlight things that we're familiar with, the PFT criteria of an FVC less than 50%, or the ABG criteria of greater than 45. But one criteria I wanted to highlight here, which is a break from our typical management, is what's underlined here in red. An FVC less than only 80% predicted in symptomatic patients. So if you have a neuromuscular disease patient with symptoms, which are now highlighted in that diagram, symptoms, including fatigue, headache, shortness of breath, snoring, pulmonary exacerbation requiring admission, if they carry a neuromuscular disease diagnosis, yet their FVC has not yet hit 50% or they're not chronically hypercapnic, but they're admitted to the hospital as a respiratory complication, currently the expert guidance is we should be trying to obtain non-invasive ventilation for these patients. But now we're at a branch point where we don't meet a qualification. If their FVC is still above 50%, how are we going to get them qualified? So a few tips and tricks there. But first, why the 80% threshold? I won't go through all the studies here, and there are other studies supporting this, but the standard of care in Europe is actually initiation at 80% or lower in symptomatic patients. And Lexin at Hopkins in 2006, Vitaka in 2017, Sarasate in Spain had an RCT in 2023, all of which showed that if NIV is initiated earlier in patients, the time from diagnosis to death is lengthened. And so independent of when you started in their course, we're still taking it from when they were diagnosed to when they died. And if you started the NIV sooner, they lived longer. And so as a consequence of this, the overarching data is supporting earlier initiation of NIV. And so in order to try to get this qualified, this is the ResMed document on qualification of NIV for patients with neuromuscular disease. And I highlighted here the FVC less than 50% predicted is the difficult thing potentially we're overcoming here. So how to get sooner? If your ABG is showing respiratory acidosis, no problem. Remember to check the maximal inspiratory pressure. So often studies in PFTs and neuromuscular patients showed that MIPS will drop sooner than vital capacity does. When I was starting off in this year, I'd see these reduced MIPS but preserve vital capacities and say, oh, it's just effort related. I'm gonna dismiss that. But really, the data in PFT in this population shows the MIPS drop before the vital capacity does. So use that as a sooner marker in order to try to qualify your patients. And then I learned this from Lisa Wolf in University of Chicago. The CMS criteria do not specify upright versus supine vital capacities. And so you can ask the PFT lab to get a supine vital capacity, have that be less than 50%, and thereby qualify your patient. So little tips and tricks there for how to get your symptomatic less than 80%, but greater than 50% patient an NIV if they qualify based off of symptoms. So back to here. So the nuances of how to get a device. So again, back to the ResMed diagram. Here on the left, we've already said neuromuscular disease. We have the kind of classic criteria of hypercarbia, overnight oximetry, or for this specific population I'm referring to, a MIP that is, and this is incorrect, less than 60. It's not less than 60, it's less negative than negative 60, i.e. it's actually more positive. So I say weaker than or less negative than negative 60. Or their vital capacity is less than 50%. And COPD needs to not be contributing significantly. So we had a patient who was admitted, a patient of Lynn's, who was now newly diagnosed with an unspecified neuromuscular disorder and was discharged from the hospital to sniff with BiPAP. And then the sniff was unable to qualify him for BiPAP and referred to me in clinic, but he left the sniff having rented the BiPAP from the sniff. And that was how he was tiding himself over, paying rental fees to Masonacare to try to keep his device covered. And so I said, let me try to take care of this. Let me get the PFT before he even sees me. And what I realized is the sniff wasn't putting the right diagnosis. They're writing neuromuscular disease, chronic hypercarbia. Those are not, according to many of the DME companies, appropriate diagnoses with diagnosis codes warranting NIV. And so you can't write diagnosis neuromuscular disease, diagnosis chronic respiratory failure. So what I've done is it's really hard to argue with this neuromuscular patient has a disorder of their diaphragm. And there is an ICD-10 code for it, and J98.6 is a qualifying diagnosis for NIV. And so if you're consulted on the inpatient neurology service, medicine, for a patient who, they have got restrictive lung disease and it's not due to parenchymal or thoracic restrictive issues, it's highly likely to be neuromuscular. You can qualify them without a specific neurology diagnosis because sometimes they're hemming and hawing with disorders of the diaphragm. In the case of this patient, he had an EMG showing, quote, sensory and motor polyneuropathy. And Daniel DeCapua wasn't able to give a definitive diagnosis, just said, this is what we see on the EMG. So I said, okay, you've got motor neurons. There's a neuropathy of them. I'm going to call you a motor neuron disease unspecified, which is not exactly what motor neuron disease unspecified wants to be, but I felt it was defensible in light of the fact that really the number of diagnoses that exist are much smaller than the number of diagnoses that require this. So for example, I have a patient with Charcot-Marie tooth. Hereditary polyneuropathy does not exist, nor does Charcot-Marie tooth as a diagnosis. And so for her, I do disorders of the diaphragm because it's often associated with phrenic nerve palsy. So need to cover diagnosis. Remember the supine FVC. And then the box all the way on the right here, the EO470, EO471, what do those refer to? So that's a BiPAP with spontaneous only or BiPAP with a backup rate. That's all up to the provider discretion. And so if you qualify the patient, you can either say BiPAP S or BiPAP ST. There's no, I have to specially qualify them to get the backup rate. If they've got the neuromuscular disease and they've got the qualifying things, you can just say, I want a BiPAP with a backup rate. And there's no further fight beyond simply BiPAP. So I would say go for the better device. So you went through all this. Why is insurance still pushing back? Well, for this reason, in 2020, a number of DME companies were sued by the federal government and found to be liable for Medicare fraudulent billing practices. So Apria was forced to pay over $40 million in a settlement agreement. And there were several issues. One, they were charging for ventilators that patients weren't using. And they were also giving kind of kickbacks to physicians or waiving certain fees in order to get more patients signed up with their DME company. But here's the one that is giving a lot of companies pause. So it's the PAC mode conduct. And what I highlighted here from the statement, the vents, we classically think of Trilogy, but Astral is the ResMed version. The ResMed Astral vent was being pushed by the DME companies when other simpler devices provided the same BiPAP ST mode. So they're saying, you really need the full vent when BiPAP could have sufficed for the patient based off of, I'm just sending them home on IPAP over EPAP with a backup rate. And as a consequence, the DME companies were getting the much greater fees for maintenance of ventilators and care of patients on ventilators when only providing the support needed for simple BiPAP to the patients. So as a consequence of getting dinged by that, and I'll highlight Apria is not the only company that was caught up in this, the companies are now much more aware. And so they're not going to give you the ventilator if you haven't specified something that requires the vent and not just a BiPAP ST. And so that prior document that I showed you here, the ResMed qualification guidelines, that's for BiPAP. It's not for a home mechanical ventilator. And so if you go through this pathway and then say, I want the Trilogy or I want the Astral, you're not going to get it. You only provided qualifications for a BiPAP ST. You need to provide something additional in order to get your ventilator. So that's why the vents are being denied. So now, and this is one of the useful slides that you might want to take a photo of, the difference between a RAD, a respiratory assist device, and a home mechanical ventilator. I'm focusing on the ResMed devices because we're going to see that a lot more in our area. Philips, and I'll get into that, not available right now, and the other devices just have much less market share. So the respiratory assist device is the AirCurve 10 ST, and the Astral is the home mechanical ventilator. What I highlighted in red is that the AirCurve ST actually has a VAPS mode. So it's not just BiPAP spontaneous or spontaneous times. It can actually provide IVAPS. And so a lot of people are prescribing IVAPS and saying, I need a ventilator for that. Not accurate. That's actually the source of the lawsuit, was that VAPS was available on the AirCurve ST. And we don't always need to reach for the full ventilator for certain patients. If you have your COPD patient that just needs high IPAP over EPAP and a rapid backup rate, they may do better with the respiratory assist device. It's smaller, it has built-in humidification, it's lighter, therefore it's more portable if they're going on trips somewhere. And it's most importantly rent to own. So after they do 13 months of payments, that's their device. And if they ever need another device in future, they still keep the one that they own. The home mechanical ventilator has many more settings. It has the VAPS with adjustable EPAP, VAPS AE. It has a battery power. It can have much higher pressures, but you rent it in perpetuity. You're spending $1,400 a month or so. Some of it subsidized, of course, by insurance, but you will spend that for the rest of your life. You never own the device. It does come bundled with the RT services, however. So the DME company is obligated to provide a respiratory therapist coming to the home, helping the patients out, doing titrations, doing downloads, et cetera. They are not required to do that with a simple BiPAP ST device. So if you have a patient that needs those RT resources, then potentially fight for the vent, but no, it's a lot more expensive versus if it's a simple COPD or CO2s on 50, you want to optimize them, the BiPAP ST may be completely sufficient without the RT support. So why the vent is not approved, these are the CMS LCD local coverage determination guidelines for ventilators. So according to the document, the legal document, they're covered for neuromuscular diseases, which is the point of this talk, thoracic restrictive, and chronic respiratory failure, quote unquote, from COPD. The disease categories they acknowledge can vary from severe, life-threatening to less serious forms. So is this mild COPD, or is this really severe COPD and the person's repeatedly exacerbating in danger of dying without a ventilator? And we recognize the ventilator disease groups overlap with those respiratory assist device categories, that ResMed document I showed you. So they say choose a device based off of patient specifics, but then have details in the medical record to specify criteria, state that COPD doesn't contribute, and then make the decision about whether you need a respiratory assist device or home ventilator. If you need a ventilator, specify VAPS AE when putting in a prescription for care in order to get the right device. So Bernardo Salim's over at Mayo, former fellow here, and this diagram is taken from his paper in 2018. So how to set it. In general, you want to set a target of around 8 cc's per kg, perhaps going up to 10 cc's per kg. One of the things we think about in our critical care mindset is, ARDS, low tidal volume ventilation, 6 cc's per kg. There's been no study that has established that high tidal volume ventilation in neuromuscular patients is deleterious. And in fact, we want to simulate normal ventilation for these patients. So we need to escape from the critical care mindset, going to the outpatient neuromuscular standard management, 8 to 10 cc's per kg. There's going to be a picture later on of a table that summarizes all this, so don't feel free to not photograph this right now. Ideal body weight, yes. You want to figure out, well, what are my pressure settings going to be in order to achieve this? You can literally titrate it in the ICU, or you could use the data you have in front of me. What is the habitus of the patient? What is their oropharynx like? If ALS, do they have bulbar dysfunction that makes me think they have kind of upper airway lack of tone? That's going to lead to increased obstruction. What do their PFTs show? How hypercarbic are they? It's a lot easier to get somebody with a CO2 of 46 to normal than it is 66 to normal. And that's going to, guide your ventilatory decisions. You want to set the EPAP as low as possible. This neuromuscular patient is going to have to exhale against that pressure. So most of the devices have an EPAP min of 4. Go for 4 if possible. But of course, you want to factor in, have they had any prior sleep studies showing OSA, and is there an EPAP that was their target? What's their habitus? Do you have an empiric suspicion that they're going to need a higher EPAP? You want to set a longer I time. So one of the failings in the neuromuscular population is to allow premature cycling. So because they have such a low PMUSC, such a low muscular effort in order to inhale, the ventilator is doing all of the work, and they need sufficient inspiratory time. So in general, you want to T-min a minimum time of around 0.8 to 1 second. And then you can set a T-max of up to 2 seconds and allow the ventilator to determine, based off of their flow, when it's going to cycle off. In general, we want an inspiratory to expiratory ratio of between about 1:1 to 1:2. Some of the ventilators report TI over T-tote, and these ratios 1:2, 1:1.2 reflect a TI T-tote of 30% to 40%, 45% rather. You want to set high sensitivity and low cycle. You want to make it easy for the patient to trigger the vent, and you want to make it easy for them to continue the breath until the flow finally cycles off and the breath is released. You want to target their backup rate generally to just below their intrinsic. You want them to guide the vent in order to have synchrony. Although if you need to drive their ventilation, go for a higher backup rate. So this is the slide that I was referring to. John Hansen-Flash at UPenn with Jason Acrivo put together a really excellent document in respiratory care in 2023 regarding essentially the Penn method of providing care to neuromuscular patients. And so this was their chart of initial settings, both for Philips and ResMed devices, whether it's simple APAP or simple AVAPs or AVAPs AE, the cycles, et cetera. So kind of what I said, easier to digest, and I'll move on after the photos. So why am I talking about Astral so much? Where have all the trilogies gone? I was almost going to sing it, but I held back. So you may be familiar with all the recalls that happened with the foam issues, the magnetic seal issues interfering with medical devices. And as a consequence, Philips had to enter into a consent decree with the FDA, and essentially they're not allowed to sell their respiratory products in the US until they've complied with all the changes that need to be made. And it's estimated maybe around 2028, they'll be back in the market in the US. But the thing which we thought was synonymous with home ventilators, the trilogy, is only available in patients who have had it previously. Anything new coming through is going to be the Astral. And there are some unique features relative to the Astral that I want to talk about in kind of the final part of the talk here. ResMed's happy, by the way, about this. So ResMed, we are all familiar with AVAPs, but ResMed talks about IVAPs. And what is that? So IVAP stands for Intelligent Volume Assured Pressure Support. It doesn't target the tidal volume. So when we have our V60s or pressure regulated volume control in the AVIAs, I forget what the acronym is now for PRVC, or the trilogies, we're familiar with VAPs where we set a target tidal volume, we set a pressure support min and max range, and the machine figures it out. So IVAPs doesn't target the tidal volume, it targets alveolar ventilation. And so it's making a calculation of you enter in the patient's ideal body weight, height, and it figures out what's the anatomic dead space. And so for each breath, we take tidal volume minus anatomic dead space, and that's alveolar breath. You multiply that by the respiratory rate, and that's alveolar ventilation per minute. So the device is targeting alveolar ventilation per minute. For each breath, total tidal volume minus the dead space. And that's the ResMed diagram of just how intelligent they are. And then it's targeting the minute ventilation for alveolar ventilation. And so this diagram here on the left is the typical, target patient minute ventilation is decreasing, ramp up the pressure. Oh, the target alveolar ventilation is too high, ramp down the pressure. So you input in the device a target alveolar ventilation and a target breath rate. So when you're writing the prescription, we're all familiar with writing in a target tidal volume prescription. That's not actually what the RT is using when setting it for the Astral device. When they're setting IVAPs, they're putting in a target alveolar ventilation. So how do we figure out what ResMed's looking for? I do want to highlight this nota bene. Since the target is a minute ventilation rate, not a specific target for tidal volume, if the patient's rate is increasing on the machine, it's going to be dropping the tidal volume in order to maintain minute ventilation. So unfortunately, in this case, intelligent maybe is overthinking it and causing problems. So just be aware that's actually one of the deficits of this IVAPS mode. So the QR code in the top right corner here takes you to a website, which is the IVAPS calculator put together by ResMed. So when you have your patient, you go to the IVAPS calculator, you enter this data here. So by the way, if any of you need to non-invasively ventilate me, these are my preferred settings, thank you. So enter in height, target patient rate of 18. I'll get into why it's such a high rate in a minute. That's the intelligent backup rate. Your tidal volume per kilogram, and you would click calculate. And then when you click calculate, this is what would appear. And so the number in blue, 8.2, is your target alveolar ventilation, is the thing that's being input into the ventilator. And you would do that in addition to that rate of 18 that I put in, and that's the prescription that goes out to the patient. Now, many of us have not been doing that, and essentially what the RTs are doing is going into this same calculator and doing the same thing, or dialing it into the ventilator itself and tweaking the numbers until they get the volume that we wanted. So what is this intelligent backup rate? The rate that you enter on ResMed devices, which are in IVAPS mode, is not a mandatory backup rate. So when you say target rate 18, that's not the vent is kicking in at 18 as long as your spontaneous rate is less than 18. It's not what's happening. So this is their diagram of the intelligent backup rate. And what's happening is they're trying to maximize spontaneous ventilation in these patients in order to encourage synchrony and patient effort. So you enter a target rate, and I told you, my number of 18. So that's what you're hoping the patient's spontaneous rate is. In the background, there's a background frequency, which is 2/3 of the target rate you entered. As long as the patient is breathing above 2/3 of your target rate, there will be no mandatory breath given. So if you enter 18, if the patient's breathing at 17, nothing happens. 16, 15, 14, 13, nothing will happen. If the patient hits 12, that's 2/3 of 18. That's the point at which the backup rate is going to kick in. So the actual mandatory rate when you set 18 is 12. And if no effort is sensed, the machine will start at 12, and then it'll ramp up the breath rate to that backup rate, to that target rate of 18 until a spontaneous breath is detected. And then it drops to that background sensing of a breath rate of 12. And so if you actually want to have a mandatory backup rate, you need to pick a backup rate 2/3 of the target rate that you enter. So if you flip that ratio, pick your goal number, multiply it by 1.5, and that's the number you're going to tell ResMed. So for example, if I want my actual backup rate to be 12, I enter a target of 18 because 2.3 of 18 is 12, or 2/3 of 18 is 12, i.e. 12 times 1.5 is 18. And that's why that's my preferred prescription on the prior screen. So what if I just want good old AVAPs? I don't want anything intelligent. Thank you, ResMed. So actually it exists. AVAPs as a mode exists, but it's hidden. It's not called AVAPs. It's called pressure support with safety tidal volume. And the way you find that, if you're in front of a ResMed Astral ventilator and you go into the screen setting the modes, you would hit the pressure support screen here. That takes you to the next screen, which allows you to set up all the settings here. Safety tidal volume is currently off. You would activate safety tidal volume, and now this window appears. And once you have safety tidal volume on, you can set up a pressure support max, a pressure support min, and a respiratory rate. And in this case, it's exactly what we're familiar with in AVAPs. You set a target safety mode tidal volume, you set a pressure support min, pressure support max, and the rate is fixed. It's an actual mandatory backup rate, nothing intelligent. You can adjust the min and max times, the trigger and the cycle as you can in other vent modes. Unfortunately, VAPS AE does not exist with this mode. So it's going to be a straight up single EPAP with the variable pressure support like our V60s have. So the ResMed summary here, IVAPS, intelligent volume assured pressure support. Remember, it targets alveolar ventilation and you can use the calculator. The intelligent backup rate is not a mandatory rate. If you want an actual mandatory, you need to target 2/3 of the number that you put in. So pick a number, multiply it 1.5. That's the number you actually put into the ResMed IVAPS calculator. AVAPS exists on this, but it's hidden as PSSVT. The rate is fixed. It doesn't have an adjustable EPAP, but one good thing about ResMed devices, when you get the device download, it actually reports an AHI. And so if you get your download and you see their AHI is elevated, you can do the work of increasing their EPAP until the obstructive events are resolved. So the take-home points for the overall talk, just be cognizant there exist guidelines for the care of neuromuscular patients and you have the reference. The barriers include getting the right diagnosis code and knowing the RAD mechanical vent criteria. You have the suggested starting settings and the nuances unique to ResMed. That's it. Thank you.
Any questions? All right. Last but not least is Dr. Kurz. We're going to talk about biologics and new anti-inflammatory treatment for COPD as a follow-up to his excellent talk from 3 weeks ago.
Thank you. Where is it? This one, thank you. Actually, Finbar, I do remember my former boss, Nick Hill, arguing with the Apria rep, why can we just not use regular BiPAP? So thanks for that late follow-up on that conversation. And I also wanted to say that we are looking on the PFT lab to get capillary blood gases. So if there is a little bit of a higher threshold, do I really need that arterial blood gas? So we're looking into getting capillary blood gases, which hopefully is going to be more accessible. But they are looking into how many blood gases are you going to get in a week or so to kind of make a plan. So just keep that in mind. All right, I try to be quick. I want to give you a quick update on recent developments in pharmacology and COPD, and I'm going to focus on two things. One, you have probably heard a little bit more about already, the dupilumab, and I also want to talk about the ensifentrine that is now being recommended. So just briefly, COPD and eosinophilia. I think you guys are aware that in a subset of patients, eosinophilia plays a role to identify patients who have at risk of frequent exacerbations. There's one study where they looked actually at the COPD gene and the ECLIPSE study to look into that issue. You know, what is kind of a threshold for a high eosinophil count that's going to identify patients that have a greater risk of exacerbation, and they identify the threshold about 300 of absolute eosinophils per microliter. Now, anybody have a guess on if you take all comers with COPD in a, in a busy clinic, how many patients that would be? How many would it be in asthma, actually? Eosinophilic, high eosinophilia in asthma population. 80%. So I think the traditional cutoff for COPD is also 150. So I noticed in the studies they have to go higher to really identify it. About 20% would fulfill that criteria. So this has been followed by a couple of studies where the use of biologics we now enjoy in our asthma population in COPD. Mepolizumab was studied at I think at a couple of doses. It was published in 2017. A dose of 100 was associated with lower annual rate of moderate to severe exacerbation than placebo among patients with COPD, stratified by eosinophil count. So they had a eosinophil count 150 and higher versus eosinophil count 300 and higher. And in both of them, they saw an effect, but it was more pronounced in people that had a cutoff higher than 300. That was follow-up with a study of benralizumab, an IL-5 receptor agonist in COPD, where they found no association with a lower analyzed rate of COPD exacerbation than placebo, with moderate to severe COPD, a history of frequent moderate to severe exacerbation, blood eosinophil counts of 220. So there have been two studies published. The latest one was essentially a remake of the first study. Was published last year, 24, where they used dupilumab, which is a monoclonal antibody that blocks the shared component of both the IL-3 and IL-13. Did I get this right? I think IL-5 and IL-13 receptor. Total of 935 patients were diagnosed with COPD and an eosinophil count greater than 300 with at least 2 exacerbations per year. They would be on stable inhaler therapy, triple inhaler therapy, and they randomized 1-to-1. Primary endpoint was annual rate of moderate to severe exacerbations. And they had an annual exacerbation of 0.86 in the treatment group and 1.3 in the placebo group. That was a total of 34% reduction. These are the graphs here. Here on the left, you have the moderate severe exacerbation, placebo versus dupilumab over the year, 52 weeks. And then the second graph, it looks like lines a little bit tighter together, is actually the time to first exacerbation. What is remarkable when you look at the twin study that was published, I think it was a year prior, the numbers look actually very similar. It looks to be a reproducible finding. Now, reduction by 30%, is that good? Is that bad? So I looked how this would compare to the asthma population. I think all comers had about a 50% reduction in severe exacerbation rates. And this may still be even more if you stratify it by the eosinophil count. So if you're more than 300, you have an event rate of 0.3, so that's a much higher reduction. So it's not as effective as our colleagues in the asthma world are enjoying, but it's a 30% reduction in that patient population. They also looked at longitudinal mean FEV1 variations, and it looked like there was a signal that patients had a little bit of higher FEV1s. I don't think like that the clinical dyspnea scores and so were significantly reduced though. So goal 25 said, looking at the subset of patients with frequent exacerbations, patients who are already on triple therapy, who still have exacerbations, several things can be considered in the subset of patients that have eosinophils greater than 300, and symptoms of chronic bronchitis, you could consider adding dupilumab. So it's a subset of patients, probably 20%, where this can be beneficial. A word on that eosinophil count. I think a lot of studies looked at, all right, eosinophil count at the time of exacerbations, hopefully before they see their prednisone. Practically, I think, looking back at what's the eosinophil count, if you have several measurements over the prior month to year, that can give you an idea if there is if that is the case. So going to ensifentrine, PDE, phosphodiesterase, and phosphodiesterase inhibitors. That is the cellular biochemistry here, which I think there are a lot of people that understand this better than I do, or remember better than I do. But essentially, it's here, it's a second messenger of all these receptors where we've got the CMP and CGMP that is exerting the biological effect, translating the biological effect. And then you have all these phosphodiesterases that essentially shut off that second messenger. So if you inhibit that enzyme that shuts off the second messenger, you have a more sustained effect of that second messenger. Here's just CGMP, for example. Now, looking at the list, there are, I think now, is it, I think 11 still counting different phosphodiesterase enzymes. I have here put a little table here about medications which we use or familiar with and what they inhibit. Milrinone, the inotrope being used in the cardiac intensive care unit, is a PDE3 inhibitor. Roflumilast, which we have been using in COPD patients with recurrent aspirations, a PDE4 inhibitor. Sildenafil, which of course affects the lungs and maybe other part of the body, PDE5 inhibitor. Caffeine, and take note, the metabolism of caffeine, PDE9. Theophylline is supposed to be a non-specific PDE inhibitor, so everything. And then ensifentrine, which we're going to talk about, is a combined PDE3 and PDE4 inhibitor. PDE3, smooth airway muscle relaxation, is the effect on for PDE4. It does have an effect on inflammatory cells. Sherwin thinks a lot about these right now, and also appears to have a downstream effect on the CFTR regulator. So it appears to be stimulating. So that molecule seems to be an attractive candidate for people who have COPD reactive airway disease. So that study was published 2 years ago, where they actually used 2 sub-studies, the enhanced trials, enhanced 1 and enhanced 2. There are a little bit tiny details how they set up the trials, but they're multi-center, they're randomized, double-blind, parallel, placebo, in 250 centers in 17 countries, and the US was one of them. So patients aged 40 to 80 were enrolled with just moderate to severe symptomatic COPD based on spirometry criteria. So pretty broad net. Stable background therapy. They were not on triple therapy at the time, and I'm not exactly sure if you're not allowed to, or they just didn't happen at the time. About 69% were on LAMA, 55% on LABA, but they're not on any combination of that. They did a 5-to-3 randomization. The ensifentrine 3 milligrams nebulized twice a day versus placebo, and they watched it for 24 in one sub-study. They did it for 48 weeks. The primary outcome sounds a little bit academic. The area under the curve of the FEV1, and they were shooting for a difference of 59 milliliters, accounting for 250 milliliter standard deviation when we do PFTs. They had a couple of secondary endpoints, a peak FEV1, St. George's Respiratory Questionnaire, and the number of exacerbations. And that's what they found. Actually, so they did hit their endpoint, the primary endpoint here in the Enhance 1 trial. Again, large patient population here, 477 in the therapeutic group, 283 in the placebo group, similar numbers in the Enhance 2. So they found an increase in that mean area under the curve of 87 and 94 respectively. What's noticeable is that the FEV1s kept dropping in the control groups over the observation period, so it would make that difference significant. That is the diurnal FEV1 variation, so over the day, right? So this is with 12 hours, you inhale it in the morning, and then you've got the trough here 12 hours later. That's the ensifentrine group, that's a placebo group, and that's why they probably came up with that area under the curve, because you want to essentially get some sort of an average over the day, how this is changing. So that was Enhance 1 and Enhance 2, pretty similar. So very well replicated. They also looked at longitudinal mean peak FEV1 variations here over the study period, 24 weeks, Enhance 1, Enhance 2, and there was a significant uptake of the FEV1 mean here from 80 to 230, roughly. That was a St. George score change with a minimal clinical difference here from -4. So as you know, if you drop your number, that means the less symptoms you have, it means the better you feel. And here in the ensifentrine group, starting at week 6, sustained benefit, sustained drop in Enhance 1, which was significant. But we look at the Enhance 2, they had actually also a dip in both, but then it looked like the placebo group was catching up. They also were feeling better. So they didn't get a significant result here, and they made some comments in the discussion why that may have been the case. I guess this is why it landed in the Blue Journal and not in a higher ranked journal. Blue Journal is great, but I wanted, they were shooting for a high journal. COPD exacerbations. So there was a signal, again, it was a secondary outcome. Here, the proportion of patients with more severe COPD exacerbations going along the line here, placebo versus ensifentrine. There was a significant difference in both Enhanced 1 and Enhanced 2. So in conclusion, both trials reached a predefined endpoint of lung function improvement. Both trials showed significant reduction in moderate severe exacerbation rates. Enhanced 1, but not 2, showed significant symptomatic improvements. So the discussion that they provided, that the placebo group showed this progressive improvement, they were speculating, or they're discussing that could be due to a higher proportion of patients with severe COPD in that placebo group who withdrew from treatment. Now, I looked at the numbers in the first study. There were like the withdrawal rate in both groups was 16 versus 13. And in the Enhanced 2 group, there was a 21% rate of withdrawal in the treatment group and a 25% of the placebo group. So maybe that explanation is sound, maybe not. I'm not sure. Interestingly, it was very well tolerated. There was similar adverse event in both groups, the treatment and the placebo groups. There was no difference in type of adverse events, including pneumonia. And compared to what we see with roflumilast, have very few GI side effects. One of the limitations that was that ensifentrine was not studied in all possible background combinations. So LAMA-LABA combination, which is now highly recommended for COPD patients, or LAMA-LABA ICS were actually excluded, or were not excluded, were not studied here. So excluded. So GOLD 25 came up with a statement when you look at the category dyspnea. So, if somebody is on bronchodilator monotherapy, which were most of these patients in the study actually, they use the combination of LAMA-LABA. And then if the addition of the second long-acting bronchodilator does not improve symptoms, we suggest, consider ensifentrine. So we have the ability to get it started. The nurses are very well educated. They have a patient, and again, looks like the indications are pretty broad. You would consider there is a process in place to get the drug ordered. So it goes through a specialty pharmacy and so forth. Now I have to say, to our own shame, it was actually the pulmonary vascular group who started the very first patient on ensifentrine. Don't see anybody left here. Wonder if we got any follow-up on that. So that's all what I have. I'm happy to maybe ask Carly and if you have any questions or. So what we heard is, and again, I'm not sure if that's the latest update, is actually you can order it. It just takes some time to get processed. So when patients say, "Hey, I haven't gotten it yet," from what we heard is there's a lot of backlog. It's being processed. It may take up to 4 weeks to get it. Actually.
Yeah. So Nino just told us that the order originally you had to fill out a paper form,
Right?
And then it gets faxed to.
Right.
But now if you can do it on Epic, you send it to the CVS specialty pharmacy, and you put in a referral to our pharmacist for a pharmacy referral to Nino, then it will be ordered there. And so you don't have to use the paper fill out anymore.
Which the nurses were doing anyhow, right?
Well, yeah, but it wasn't really happening, but that's the new workflow if you want to order it.
has changed. I was on St. Rayfield.
Yeah, yeah. So that was the new workflow that he just told us about an hour ago.
So, I mean, I just think, thanks, Sebastian, for, updating everyone on this. We're always looking for new things in our toolbox. And of the things that I think our team is most excited about, ensifentrine is one of them. Certainly the biologics for people with a eosinophilic profile of COPD and a Th2 features. It's also great because of recurrent exacerbations. We need additional things there. But this is just to call out a treatment that may be particularly helpful in people who don't have Th2 high profile of inflammation. And that's something we've been lacking for a while. I think there's a lot of unanswered questions, one of which is that was brought up by Sebastian, which is we don't really know for sure that this does provide the same benefits that were shown in the enhanced trials amongst people who are already on triple therapy, for one thing. We also don't know the impact yet on exercise outcomes, on dynamic hyperinflation. We don't really know a lot about the mechanistic things that are happening on the inflammation side, but these are all exciting areas for future study. And so we have a lot of ongoing dialogue in our group with the company, looking for research opportunities and trying to see if we can make further inroads into what this medication is actually doing and whether there's subgroups who benefit more than others.
I don't really do clinic, Sebastian. But I do see a lot of patients in the unit who have recurrent admissions, recurrent exacerbations. Would you say that if we have those patients that a referral to consider initiating this medication would be warranted, or?
I think we'd like to see these patients no matter what, and, try to get them in as soon as possible. I know we had a couple of very frequent flyer that kind of missed a pulmonary appointment because they keep going to the hospital. One of them I saw at St. Rayfield in the ICU actually, who actually has a very high eosinophil count, which we think, yes, he should be started. So we tried to streamline discharge, pulmonary follow-up, hopefully getting him on the drug. And so we'd like to see them anyhow. So, and even if that is a special consideration, we're more than happy to get them in.
All right. It's late. We'll make this the last one, Kerry. Get the honor.
Yes, the honor of last question. So one thing I just wanted to say for fellows in particular, this is the first drug combined PD3, PD4. There was nothing like this before. And it's a new mechanism in inflammation. So PD3/4 can be downstream of Th1 and Th2. Like both of them can be using. So non-eosinophilic COPD, this can work on. It seems like it's very strong for bronchodilation. So the question to Elaine is, this is a nebulized medication. Is it possible for somebody who does not respond to steroid and bronchodilators, everything on a vent, is it possible to give it? Is it possible? Like, we have had those kind of patients.
It's not available for inpatient.
Yeah.
It's only available for special.
Yeah, it's a special pharmacy. I'm saying
And you cannot use a mesh nebulizer because it's a suspension, remember?
Yeah, that's right. It's a different nebulizer. It's a different nebulizer. So just that for thought. Not respond to anything.
All right, so Elaine will get a button for that on the ventilator at some point. And a special
Meanwhile,
nebulizer.
you have to
Anyway.
adjust your theophylline vial and.
All right, well, thank you to our three speakers and everybody for hanging in there for our talk. Thank you.